And we're live. Good afternoon, LinkedIn. It's Marion Spears Carr, and it's the Healthcare Thought Leadership LinkedIn live show at a special time at 2 o'clock in the afternoon on Friday. Hope you all are doing well and ready for the holiday season. Very honored today to be talking on a topic that we've been covering in a lot of different ways around why disruption and innovation is so important and paramount in today's healthcare world. And today I'm really honored to have my guest, who's Ann Summers Hogg. She's the director of healthcare research at the Clayton Christensen Institute. Ann Summers, it's so good to have you. I'd love for you to tell us a little bit more about your background, your years at Atrium, and now obviously the work you do at Clayton Christensen, and we'll jump right in on our topic here. Welcome to the show.
Well, thank you so much for having me, Marianne. I'm really excited to be here. And as you mentioned, I'm the Director of Healthcare Research at the Clayton Christensen Institute. For those who aren't familiar with the Institute, we are a nonprofit, nonpartisan think tank dedicated to improving the world through disruptive innovation. And the research that we do is all based in the theories of the late Harvard Business School professor, Clayton Christensen. You likely know him for his theory of disruptive innovation, but he has many others as well. Jobs to be done, business model theory, which I think we'll touch on today, are just a couple of them. And in my work at the Institute, I lead our healthcare research. And I've been at the Institute for about 2 years now. And in my time here, my research has focused on the drivers of health, also known as social determinants of health, but I prefer drivers of health for a couple of reasons. Maybe we'll chat about that later.
I'd love to know. Yeah, I'd love to talk about that. Yes.
Great. As well as maternal health. So those have really been my two focus areas. Before joining the Institute, I spent 8 years at Atrium Health, now known as Advocate Health. And in my time there, I worked in innovation with the innovation engine, as well as in corporate strategy. Before that, I started my career in strategy consulting, working with Oliver Wyman, predominantly focused on the payer side as opposed to the provider side, developing value-based care models for large payers.
A whole bunch of different paths led me to this conversation, led me to you. One was I actually had Todd Dunn, who's the VP of Innovation at Atrium, now Advocate, on my show a few weeks ago. And that's how I heard about you, but also in the work that I do. And by the way, for those of you who don't know me, I am an executive search consultant, a leadership development person who works in the world of healthcare and life sciences and value-based care, particularly from the perspective of what organizations are doing to meet the needs of patients within that framework. From a leadership perspective is really one of my key focuses. If you're new to Healthcare Thought Leadership LinkedIn Live Show, this is a show that I created about a year, almost 2 years ago. I think we're up to about 75 episodes now, where I introduce people in my network and share them with my network and beyond that. If you're watching live, please let us know in the comments that you're on that you're on and you're watching. I've already, Laura Berger's checking in from Davidson, North Carolina. Good to see you, Laura. Michelle DeStefano, who is a former chief nursing officer and a coach now down in San Antonio. Leslie Kincaid, checking in from Springfield, Missouri. And Summers, when we started talking about you coming on the show, one of the things you sent me a bunch of different things about some of the research you guys were doing. There was a whole bunch to unpack, but one of the articles that stood out to me was the article that was titled, You Are What You Treat. And you really got into this idea of, excuse me, kind of the problem that needs to be solved within the world of healthcare from that perspective. But what are the challenges? I'd love for you to talk a little bit about that. Kind of what is the problem that you're focused on solving?
Yeah, that's a great question. And just for a little bit of background, You Are What You Treat was our first report that we wrote on the drivers of health. And we really entered into this research with the question of, if as a country, we've been trying to improve people's social determinants of health, aka drivers of health, we've been trying to do this for a while, at least a decade, but really much longer than that. But we aren't seeing a lot of progress. So why has there not been a lot of progress nationally? And then why have some innovators been able to make progress? So what delineates those who are able to effectively impact drivers of health from those who aren't? And what it really came down to was business models. So if we think about what's the problem to be solved in order to better address drivers of health and improve people's health outcomes, their health-related quality of life, and ultimately lower the cost of care, the root of the problem is entrenched business models. Now, what I mean by that, actually, you mentioned Todd Dunn, and he used to say something to me that I love to repeat, which is if you ask 100 people to define business model, you'll get more than 100 answers, because a business model is, people say business model all the time, but it's actually not always a well-defined or well-understood term. But at the Institute, sorry, go ahead.
No, so absolutely. I was just agreeing with you that there's so many different definitions of that term. So anyway, continue. My apologies. I was just getting excited about what you're talking about.
Oh, no, definitely. And so at the Institute, we use a 4-box framework to talk about what we mean by a business model. And it has 4 parts. The first is the value proposition. So this is the promise that you make to your customers, or what you're offering to the market in order to help your customers or consumers achieve their desired progress. The second component is resources. So these are the assets that your company uses in order to deliver on your value proposition. Third is the processes. So these are the repeatable ways of behaving that the resources in an organization execute in order to deliver on the value proposition. And then the 4th box is profit formula and priorities. So profit formula, how do you sustainably and consistently make money? And then priorities, what are the organization's priorities that dictate what they invest in and what they don't? So 4-box framework, value proposition, resources, processes, and priorities. And there are a lot of frameworks out there. This is just the one that we use at the Institute. Another really great one is Alex Osterwalder's business model canvas, which I have found is really great for practitioners who are seeking to build new business models from scratch. And they want to, I find the canvas really useful if people want to really flesh out how the different components interact with one another and what are some key assumptions that they might need to test about this new business model.
Exciting. And by the way, we got a lot of people checking in. Again, if you're watching live, we'd love to see you in the comments. And if you have questions for Ann Summers, please, as we discuss this is always an interactive show. That's the whole plan. We've got Dr. Sadek checking in from South Carolina. Marie Julia Clemens is checking in from Florida. Chuck Hall from Conyers, Georgia, right down the road from where I'm at. Trent Good is checking in. He's an up-and-coming and very sharp leader in healthcare, checking in from Atlanta. And then Dr. Mark Schnitzer is checking in from Dallas, Texas. Great to see everybody. And Drew checking in from Winston-Salem. And there's a question. Can you repeat the briefly repeat the 2 business models for Marie? That one, she was. Sure. I think she was taking notes. Marie, thanks for the question.
Definitely. So the 2 frameworks. One is the framework that we use at the Christensen Institute that was developed by Clay Christensen, and I can actually share a link with you, Marion. I'm sure you can tell me how to do this to point you to a brief primer on basically what I said out loud, but it's all written down.
So if you'll drop it in the private chat, then I'll share it with the group on the chat. Yeah, that'd be good.
I will do that. And then the second one is Alex Osterwalder's business model canvas. So if you Google business model canvas plus Alex Osterwalder, it'll come up.
One of the things you and I talked about was the fact that healthcare leaders, and in my world, I deal with mostly healthcare delivery companies that are doing they're front facing with patients, be it hospital systems or physician practice groups or ambulatory surgery centers, and the world of private equity as well. But one of the things you and I talked about, and you talked about it in your article, was this idea that there's a lot of leaders who want to address these determinants of health, but don't have the tools to do so, which is what the conversation is. Talk a little bit about within your research, how are you equipping, so what's the process, what are the steps to start solving this problem? You mentioned the 2 business models, but would love for you to talk about maybe an example of how you're helping leaders be innovative and make those changes.
Sure. So it might help a little bit if I just give a bit more background on how we came up with the ultimate business model framework that we shared in the paper.
I think it'd be really valuable.
When we went about the research, again, looking to see what sets the innovators apart who are able to improve health-related quality of life, improve health outcomes, lower total cost of care by addressing drivers of health versus those who aren't. What is it about their business models that sets them apart? Mm-hmm. So first, in order to find the innovators, in order to find those bright spots, the positive deviants in the field, we did a national scan. So we looked at about 85 organizations of all various types. So we looked at providers, we looked at payviders, we looked at payers. Although, are there really any pure play payers anymore? That's probably a different conversation, but I'd argue
that's another show. That's a whole other show, matter of fact, yeah.
We looked at community-based organizations. We looked at governmental organizations. We looked at this whole bucket of business models that we labeled enablers. So if you're familiar with drivers of health, those would be the like now pals of the world. Yeah. We looked at them, and then we looked at entities who were seeking to try and disrupt healthcare in some ways. So what we looked at those 85 different organizations, and then we focused in on 15 that we did interviews with. And we mapped their business models based on our interviews, and we looked for themes across the different, innovative approaches. And basically, we came up with one thing in each box that really set them apart from the rest. We actually had 5 to 7 things in each box that set them apart from the rest. But my great boss at the time, Rich Alton, who leads our emerging research, said to me, "That's way too complicated. Can you just get it down to one?" So
keep it simple. I got it.
So when it came to the value proposition, what we really learned was that organizations that were focused on enabling both consumers and customers, because in healthcare, those aren't the same, to achieve their job to be done or the progress that they were seeking in a given situation. The organizations who had grounded their whole business model around helping people achieve their goals were really the ones who were winning in the end. And I think one of my favorite examples of this is a company called Factor Health, which actually came out of UT's medical school in Austin. Okay. And it's not a provider first model. So the goal is to deliver health in the fabric of people's lives. So in the rhythm of their lives. They don't start with the clinic. The clinic is actually almost an afterthought. So what they did was they went to consumers. They learned about the consumers in their immediate area and learned what are some big pain points that people are struggling with. And then they went to payers to understand what are some of payers' big pain points. They identified the overlap where there weren't good solutions. And one of their first interventions was around loneliness in seniors.
Wow.
And so by leveraging lay people, they used students at UT Austin. They taught them how to be empathetic interviewers. And they had these college students call seniors who were at risk for loneliness as well as food insecurity. And over a 6-week period, they found that these conversations that with lay people who they had trained in empathetic listening improved PHQ-9 scores, improved GAD-7 scores, improved quality of life as self-reported by individuals.
Wow.
And we know that loneliness is a precursor to chronic conditions, and those are really expensive. So payers were very excited about this. Their payer partner was really excited about this, that they had found a cost-effective way to impact loneliness. And what I love about their model is they really took a twofold approach, and they didn't start with how can we change the healthcare clinic or the provider's office to address loneliness. It was how can we go outside of the providers, not give them one more thing to do, and actually address this with a solution that might not require a provider at all. So that was a really, really interesting component of their model.
I love that. I'm a big student of the single loop and double loop learning model, where you think about, are we solving the right problem? And I love the idea that they flipped it on the end. Instead of focusing on how can we have a better clinic or have a better care delivery model, they're going back to root cause of by connecting with these seniors. And when you mentioned food insecurity, that's people don't think about that. Like, I've volunteered in a lot of food banks, and until I started doing that, I did not realize that the level of food insecurity, particularly with seniors around the country, it's amazing. And then connect that to the dots to the loneliness component. I didn't know about that piece. That's amazing. I love that example. Laura, I'm going to jump back. Laura Berger has a question, a couple of questions here. I'd like to jump into that. I want to come back to our conversation, but I think these are Laura, tagging on your thought. We haven't done a very good job with social determinants of health. What are some of the ideas? And I think you're talking about that, of how to change that, or perhaps it's which business model better suits improved overall health. And I think you're talking about that. But Laura, thank you for the two questions. What are your answers? I'd love for you to maybe, I think you're already addressing that, but I'd love for you to speak a little further on it.
It's a great question. And I'm actually going to start with something that Clay Christensen said, and I won't get the quote exactly right, but he was being interviewed about disruptive innovation and why it was that incumbents were able to be disrupted. And he basically says it's not because of poor leaders. Like, it's not a bad management problem. Mm-hmm. It's actually that the leaders are so good at consistently doing what has led to success in the past, mm-hmm. that they keep doing that. And therefore they miss the disruption. And in looking at drivers of health, it's not a leadership problem. It's not just an incentives problem. It's not just the profit formula box of the profit model. Of the business model. It's actually the whole component. It's the business model in its entirety. And that's because of the way business models work. So when startups launch a new business model, mm-hmm. all the components of their business model are malleable. And over time, they figure out what are the resources, the processes, and the profit formula that we need in order to consistently deliver on our value proposition. Mm-hmm. And once they figure that out, the repeating of the cycle, repeating of the processes makes the business model components get tighter and tighter over time. And because that happens, you can't easily pivot a business model mm-hmm. to deliver on a fundamentally different value proposition. Because over time, as it gets more and more ingrained at doing what it does well, it gets less good at being nimble and changing easily. So what we found was that organizations whose incumbent business model was really focused on traditional fee-for-service sick care, mm-hmm. they couldn't easily pivot to a completely different value proposition around prevention and keeping people well and addressing their nutrition needs and ensuring that they had access to safe housing. Those are you need very different resources, processes, and profit formulas to deliver those two different value propositions. So for incumbent organizations that were making a big impact on drivers of health, what we found was that they tended to have, probably not surprisingly, value-based payment models as a core component of their profit formula.
When you shared that quote with me yesterday when we were talking, and I wrote it down, and the key thing that struck me about it, and you and I talked about this yesterday a little bit, is this idea that these people are so good at their leadership skill set, that they've done so well that sometimes they can't even see that they need to make a change in a different context. And we talked about context. Let me ask you this question, and by the way, if you're watching the show for the first time, this is my weekly healthcare LinkedIn live show called Healthcare Thought Leadership. I'm Marion Spears-Carr, and I'm just glad to have you with us. Cheryl Halbert actually has helped us out and posted a business link to the business model canvas in the chat, and we'll also get that link from you. Someone's checking in from Stamford, Connecticut as well, and someone also mentioned that you were talking about a holistic approach. Let's go back. I want to go back to this question. We're talking about problem solving. We've kind of identified that. You've talked about I love that great example. Here's a curveball. In some words, I told you this would happen. Where are some resources for these leaders to get educated in the work that you're doing? And obviously, they can come to the Clayton Christian Institute, read y'all's work. but how can they get even further involved? And then we're going to talk about why it matters. But I would love for you to, how do they get involved? How do these leaders that are doing so well, as you've talked about, but now have, the context in my mind has changed. Where can they go? What do they need to do? How do they need to get engaged with this work in a meaningful way? And I know that's a question you didn't expect, but I
no,
wanted
that's
to
a great question. I love it. We're good. I love tough questions. They're more fun. And so a couple answers. One is we are a nonprofit and all of our research is available on our website. So it's available to you for free. So if you go to christenseninstitute.org and you click on our blog and then you click on healthcare, you can find everything we've written about healthcare. The first thing I would point leaders to is the report that I've been talking about and that you started with, which is You Are What You Treat. And this is where we provide the business model compass for leaders who are wondering, what does my business model need to look like if I want to impact drivers of health? The second paper that we wrote after we wrote that one was called Improve or Transform, Choosing the Right Business Model for Health. And the reason we wrote that one was a compass is one thing, but based on my experience talking to leaders across the country, as well as my decade in the industry, what I really took into this position was knowing that leaders who are leading health systems today are very focused on today and the problems that are in front of them today, as they should be. And so having somebody just give you a compass isn't necessarily as helpful as someone giving you a how-to guide, because business models and strategy aren't one size fits all. They're really context dependent. So it's really important that your strategy and your business model fit your organization and the context, not only that you're in today, but what it is that you believe about the future. So in Improve or Transform, we created a how-to guide that includes both a strategy guide and a decision tool to help leaders understand, how do I set my strategy and then choose the right business model to match it. So in the strategy guide, we basically walk leaders through, how do you set your mission, vision, and beliefs about the future? How do you map your current business model viability and then assess whether it will continue to be viable in the future? Because if you're in a position where your current business model's viability is declining and it looks like it's not going to be sustainable in the long run, then you don't just want to ride it into the ground, right? You want to pivot now and have a better solution for the future. And then the third component is assessing the risk that you're willing to take on, because different leaders in different environments and different contexts are willing to take on different amounts of risk. And whether you improve your business model or transform it is dependent on, yes, what you believe about the future, your current viability, but also how much risk you're willing to take. So I would say those two reports would be helpful to leaders. The other thing I would say, if you really want to get steeped in the theory, if you really want to understand how to go from theory to practice and apply Christensen's theories to your work, we offer an executive education course that's online, and it's live. So you're interacting with other researchers and experts from the Institute who are doing the teaching. And then also you're interacting with your cohort. So we either do that, an offering a few times a year where it's open to any and everybody. And we also offer for specific organizations, if they say want to train 10 of their leaders at a time, then we offer something like that.
Outstanding. And I'm very fascinated with leadership learning, and it's been something I've been just incredibly like full in on for a while now. And I love the innovative nature of that. Let me ask you this question. When we think about, and by the way, the time's flying. If you have questions, if you're watching live, if you have questions, Brandon Summers, please put them in the chat. Because we love to answer your questions. I do want to bring up this comment. This underpins something you said earlier. This underpins the reason healthcare and CMS have not been able to affect a paradigm shift managing complex chronic diseases. I think you were talking about that. I would love for you to speak on. I want to switch gears though. Thanks for that comment. You're also focused in the maternal health space. Tell us a little bit about that research, because we know that maternal health is such a big deal, but women drive decision making in the home of what healthcare is going to be accessed, how they're going to access healthcare. They make a lot of those decisions. So when we think about maternal health, that's oftentimes the entry point into their experience in healthcare. Talk a little bit about that research. I know that, again, switching gears, but I just thought about what you were doing. I wanted the audience to know about it. So there we go.
Thanks. Yeah, happy to talk about that. And the latest report that we released from a healthcare perspective was around maternal health, but probably not the area of maternal health that you have heard most about. I would imagine all the listeners on this call are very familiar with our maternal mortality ranking in the United States and how our rates are getting worse and how they are especially bad for our Black and Brown populations. But what this report looked at was actually the health over the life of the mother. So we looked at maternal health and maternal health outcomes broadly, assuming that they actually survive that first year postpartum, which again in our country is not necessarily a great assumption to make. But if they do, then we looked at what are the health burdens that moms face, especially the moms who work outside the home. So all mothers are working mothers, but moms who are employed by not their household. So what we found was that working mothers actually have worse mental health outcomes, worse physical health outcomes, and also suffer from disproportionate economic burdens that working fathers and coworkers who do not have children or do not yet have children don't face. So in terms of burnout, anxiety, depression, and then multiple chronic diseases, working moms are much worse off than their counterparts. And what this paper looked at was not only the health issues that working moms are faced with, but what do we do about it? So the first thing we looked at was what efforts have we attempted so far and why have they not worked? And then we proposed a path forward. And we looked at this problem through the lens of another one of Clay Christensen's frameworks called the tools of cooperation. And this is where a visual would be really helpful, but I'm going to try and draw the picture in your mind. So think of a 2x2. You've all seen 2x2s before. So on the vertical axis, you have the extent to which people in an organization or a society agree on a goal. So at the top, there's high agreement. At the bottom, there's low agreement. On the y-axis, you have the cause and effect. So how much do people agree on how to achieve that goal? And then there are 4 different quadrants. And within each of the quadrants, there are different tools that leaders have at their disposal. But what's really important about the tools of cooperation framework is most of the tools don't work most of the time.
Wow.
So you have to leverage a tool that's aligned to the quadrant that you're in. So if you have really high agreement on a goal, we want to reduce maternal mortality, and really high agreement on how to get there, then you would be in the culture tools quadrant. And in the culture tools quadrant, things like national policy change work really well because culturally you agree on the goals and you agree how to get there.
Mm-hmm.
Policy change doesn't work really well if you're in the lower left-hand quadrant where you don't have agreement on the goals and you don't have agreement on the cause and effect.
Wow. I could see that. Absolutely.
And when it comes to health over the life of the mother, we don't necessarily have goals that we agree to nationally on what improving this health looks like. And because we don't know what improved health looks like, we aren't really clear on how to get there. So we proposed, actually, instead of starting at the national level, where a lot of efforts have started and haven't necessarily worked, that actually where we might see better progress is if we start within a employer organization, a large employer organization, where there's at least agreement on the goal. So the goal is perhaps that we need to promote better maternal health outcomes, better maternal well-being, because that's really beneficial to the organization. We know that companies that are run by women who, as their CEO, have better returns than those run by men. And so for an organization that really wants to build their female pipeline, it's important to really invest in females. So why might we think a forward-thinking employer could be a place to start? Well, if we look historically at the US, we have a 40-hour work week right now. We know that a lot of 4-day work week studies from other countries have shown that mental health outcomes can be improved, productivity is higher, and actually employers see a return when they go to a 4-day work week.
Wow. Okay, I get that.
We also know that in the United States, we lose $55 billion in productivity each year because of the misalignment between the work and the school schedule.
Wow.
So maybe a 40-hour work week isn't really the best fit. But if we look historically, we used to have a 48-hour work week. And it wasn't the Fair Labor Standards Act of 1938 that changed the 48-hour work week to the 40-hour work week at first. It was Henry Ford. Henry Ford was a forward-thinking employer who thought that that people weren't productive for 48 hours a week, so he went down to 40. And then he did that, I believe, in 1915, 1914. And then almost a little over 20 years later is when the Fair Labor Standards Act made it 40 hours a week for everybody. So there are a number of paths that employers could take, forward-thinking employers could take to promote maternal health. But one of them might be aligning the school day or aligning the work day to the school day. Because when you look at the life of mothering, yes, the first 5 years are incredibly important. So we should continue to pursue things like universal paid leave, affordable childcare, access to affordable childcare, et cetera. Those things are all very important. But the most conflict over the longest period of time is actually the conflict between the work and the school schedule. Because from kindergarten all the way to age 18 or perhaps 19, that's like 15 years of schooling.
It's a lot of time. Yep.
It's a lot of time, 14, 15 years. So what we did was we leveraged the tools of cooperation and really looked at what are some potential avenues that employers could take in order to lead the way on improving maternal health while also improving their bottom lines.
Such great conversations around innovation and business model change. And we're actually gone over time. Laura has asked a question. Laura, I'm going to ask Ann Summers to answer that in the chat, maybe, because it's a great question, but we've run out of time. In your opinion, is the environment right to foster public-private partnerships and collaborations to improve certain kinds of health issues? And you can give a short answer on that. I love this idea I'm glad we got off the tangent, because I think onto a tangent. And if you've ever watched the Healthcare LinkedIn Live show of mine, this happens every show. So just welcome to the show. But any final thoughts, Ann Summers? Thank you for being, and those of you in the audience, thank you so much for watching. Please share it. Any final thoughts?
Thank you so much for having me. To Laura's question, I would just say yes, absolutely. And I didn't even get to this box on the business model diagram for the organizations that effectively impact drivers of health. But one of the key resources they had was what we ended up calling a partnership ecosystem. And it was just that. It was an ecosystem of partners across the private and the public sector.
And what a great way to tie a bow on it. If for those of you who want to connect with Ann Summers, connect with her on LinkedIn. If you want to send me a DM, I'll send you her LinkedIn if you can't find her. And if you're not connected with me, if this is the first time you want the show, please send me a connect request. You can hit the follow button, but also send me the connect request. And Summers, have an amazing holiday, and thank you for being on the show. This is the last show for the season, and just glad to have you. And we'll go off the air now. For those of you, if you're live in the chat, if you let us know what you thought. Doug Luckett has already checked in and said thanks, Marion, and I think Ben Jones shared your image for us. Thank you for being with us. Have a great day. Merry Christmas, Happy New Year, and Happy Holidays to everyone. And I'll see you again soon.
Thank you, Marion.
You're welcome.